Good afternoon, ladies and gentlemen, and welcome to the afternoon panel session. My name's John Olive. I'm from the University of British Columbia, and with Olivia's really kind invitation, I'm here to moderate the session today. It's a bit of a challenge for me for a few reasons, because I have to be organised and I have to think and I have to keep things in control, and that's not really my strength area, but nonetheless I will do my very best. A couple of housekeeping things. These are really a message to myself, but I'll share them with you. What I will do is I'll introduce the speakers one by one, and there's 4 of them, and they'll speak for 15 minutes each. What we'll do is we'll hold the questions until the end, and ideally we'll have 30 minutes to really engage a conversation. I have these 2 placards, and I will be keeping time, and I'll be pointing these towards the speakers if they, as they get close to the end of their 15 minutes. I have a rare source of earlyism, and so I could display these at any point for the speakers. They might get 15 minutes, they might get 20, who knows? But I'll be working with those placards as we progress. I think it's a fascinating topic and a really meaningful topic. I was in a symposium not so long back where they were talking about suicide and the epidemiology of suicide in Canada, and going out and finding out the actual numbers and the issues around suicide in a way of thinking about suicide prevention. And that was in November of 2012. So I think the topic is kind of been latent, but nonetheless incredibly important. So today the topic is called Suicide Amongst Gay and Bisexual Men who are affected and how can we improve prevention. I'll begin by introducing our first speaker, Travis Salway Holtz. Travis is interested in health inequities experienced by LGBT populations. He's currently pursuing a PhD in epidemiology at the University of Toronto and serves on the board of directors of the Communitybased Research Centre for Gay Men's Health. He's worked in various public health and HIV agencies, service agencies for the last 12 years. Please join me in welcoming Travis to the podium.
Okay, thanks, John. So I have 2 stories to share with you today in my presentation. The first is about suicide. So at last year's summit, I raised some questions around how much do we know about this topic, and a lot of you were very supportive and encouraging. And since then, I have spent some time kind of getting into the literature on this topic. I'm going to share with you a little piece of that today. But the second story is really about how those of us who do community-based research describe and defend the methods that we're using to the larger community that's trying to make sense of all of the data around sexual minorities. So that's a bit vague, but hopefully the point will become clear as I go on. So the first study that attempted to quantify the problem of suicide in gay and lesbian people was conducted by Bell and Weinberg. These were researchers from the Kinsey Institute. And in the 1970s, they went to San Francisco. They sampled about 1,000 gay and lesbian adults living in the city, and they found that 1 in 5 of them had attempted suicide in their lifetime. This was 6 times higher than the rate of suicide attempts in a comparable heterosexual population. 5 years later, Eric Rofus wrote about this issue as a rallying point for gay rights activists. And in his book, he tried to explain some of the reasons for the higher rates of suicide. Most notably, he talked a lot about the threat of exposure as being gay or lesbian for people who weren't out. In the subsequent 30 years, 2 types of quantitative evidence came out on this issue. The first were community surveys. Most of you will be familiar with this method. This is surveys collected at pride festivals, at bars, gay businesses, etc. And they showed comparably high rates of suicide as shown in the Bell and Weinberg study. About 1 in 5 of those respondents had attempted suicide, but those studies were quickly dismissed as not being valid evidence, in part because they were described as not being representative of what, I'm not quite sure. I'll come back to that point later. But in the face of that critique, a lot of gay health researchers worked really hard, particularly in the States, to get measures of sexual orientation added to population health surveys. These are those random household surveys where they go out and they collect people from a representative set of households. And sure enough, those surveys showed the exact same pattern. In 2008, we had a first systematic review on this topic based on that second form of evidence on those population surveys that showed that gay and lesbian people were about 4 times more likely than heterosexual people to have attempted suicide. A few years later, a second systematic review found this was also true in school-based surveys of youth. And last year, a third systematic review looked specifically at the evidence for bisexual people and found they too had consistently higher rates of suicide behaviors. So you're probably asking, why am I standing here doing a fourth systematic review? I am coming to like systematic reviews, so that's part of it. But also, I think there's still some gaps. So first of all 3 of these systematic reviews had really high variability in the studies that they included in the review. Some surveys showed astronomically high rates of suicide attempts. Half of the sample had attempted suicide. Others were more moderate, albeit still higher than the rates they were seeing in heterosexual groups. So why? Are there any aspects of these studies or of the samples that can help explain why some of the rates are so high? The second and the most important reason for me is that the systematic reviews excluded the studies which sampled gay people through gay venues. They excluded the LGBT community samples, and I'm going to talk about later why I think this really matters. But for now, as most of you know, we'll just say that these studies that are based in communities, that are community-recruited samples, really provide a very different kind of knowledge from the general population health surveys, and a type of knowledge that I think we need to listen to. And finally, some of these reviews, and a lot of the evidence has been focused on youth. So I want to take a minute just to expand on this point, because the results I'm presenting today are really about adult sexual minorities. So there seems to be a general assumption in much of the research published on this topic that where sexuality becomes an issue in relation to suicide, it's predominantly a phenomenon of youth. And by the way, it's not only researchers who've come to this conclusion, but also a lot of people providing services, providing information. So when I go to the Canadian Association for Suicide Prevention website, LGBT youth, but not LGBT adults, are listed as a priority or a high-risk population. So I'm curious about how we got here, and I think one of the ways some researchers have reached this conclusion by looking at longitudinal patterns. So they've taken some of those population-based surveys, such as the longitudinal adolescent health study in the US, and they looked at adolescents who reported same-sex attractions, and they found that they had a higher rate of suicide relative to their heterosexual peers, but that over time, when they followed them into young adulthood, this effect diminishes. So the problem with this argument is that, first of all, in everyone, irrespective of your sexual orientation, non-fatal suicide attempts are highest in the teenage years, in your late teens, early 20s, and they decrease steadily over time, as you can see this purple line here. In the meantime, fatal suicides, so actual suicide mortality, has the opposite pattern. It increases with age. This is the green line you can see here, right through middle adulthood. Consequently, if there's any increased risk in middle adulthood related to sexuality, related to being gay or bisexual or another sexual minority, this will produce a large number of deaths, a large burden of suicide in our community. So I think we need to be a little bit more, this is kind of my nerdy epi way of describing it, but we need to be a little bit more critical of this information before we decide that this is only a phenomenon of youth. And maybe a more relatable reason for why I'm thinking about adults today is that minority stress that we experience for being sexual minorities doesn't just disappear when we become adults. It's probably true that there is something very acute and particular about the stressors that adolescents face if they have a non-dominant sexuality. And that's something Dr. Saywick, I think, will talk about a little bit later. But we also know that gay and lesbian adults have to continue to come out when they're older. They have to continue to manage their identity in the face of discrimination. This article was in the Globe and Mail earlier this month, and when I read it, it reminded me of this topic because it talks about gay and lesbian adults who are experiencing some challenges when they're trying to access housing and senior services. So it doesn't just magically disappear when we get to adulthood. So with all of this in mind, that was a long introduction, I had 3 questions. I like lists of 3, apparently. The first was, how strong is the evidence for elevated suicide behavior right through adulthood for sexual minorities? The second is, are there any aspects of those studies that will explain the variability that we saw in the previous systematic reviews, and then where are the gaps? So I searched 5 databases. These include the most commonly used biomedical, psychology, and social science databases. I looked for any survey which tried to estimate suicide attempts or suicide ideation in sexual minority populations. I did set aside the studies that were really focused in more specialized settings, for example, psychiatric clinics. And this search turned up 1,600 abstracts. So I spent a few weeks of my summer reading these abstracts and whittling it down to 145 relevant publications. Today, I'm going to set aside the 100 papers which are really focused on adolescents and young adults and tell you about the 50 or so publications, well, 35, which met my inclusion criteria, which are looking at adult gay, lesbian, bisexual, sexual minority populations. These included 37 studies across the 35 papers and 129 subgroups. So if one survey separately reported information on suicide among lesbian women, bisexual women, heterosexual women, those are 3 different subgroups in my analysis. Here is a table that gives you some sense of where the studies took place and how they were conducted. You can see about half were in the US. I did have 5 Canadian studies. 40% were these random population-based surveys where they do random digit dialing or go to households and then they ask people within those surveys to identify as gay or lesbian or bisexual. And then 60% of sort of our community-based surveys, sort of like Sex Now. In terms of how they administered the surveys, about 35% relied on an interviewer who either over the phone or face-to-face had to ask that person questions about suicide and sexuality. And then 65% were self-administered, either on paper or online. And by far, the most common outcome reported across these studies was lifetime suicide attempts. You can see 31 of the 37 studies reported this outcome. So that's what I'm presenting today, because that's where we have the most data. Although all of these outcomes, I think, are worth looking at more. Okay, so on to the results. This plot, I won't make you do much with this plot. You'll just have to trust me when I tell you what it is. It's a forest plot. Every line is a study included in my review. And basically the bottom line is, of the 31 studies that looked at this outcome, all 31 showed elevated rates of suicide attempts relative to heterosexual populations. On average, 17% of sexual minorities had attempted suicide in their life as compared to 4%. But there was a range. You can see it went anywhere from 8% to 36%. So those are very, very different studies, and I wanted to know why. So I came up with, I actually have a much, much longer list of variables that I looked at, but because I only have 15 minutes, I just picked 4. I'm trying my best to stay on time. Thank you. So I wanted to know, okay, maybe we know age is a factor in relation to suicide. I showed you those graphs earlier. That's a big factor. So maybe something about the average age of the sample matters. Maybe the year in which it's conducted, because I think it is true that depending on where you live and who you are, there are calendar year effects in how we experience discrimination and stigma. The one that I'm really going to focus on is sample type. Did it matter if the study was recruited through a community-based venues, bars, websites, et cetera, or the random population surveys? And then lastly, I looked at whether it was interviewer or administered or self-administered. Okay, so I'm going to show you 4 graphs, one for each of those 4 points. The first 2 graphs, every dot represents a subgroup from a study. Okay, I have 5 minutes, so I'm going to talk quickly and you'll have to listen carefully. The red dots are sexual minority subgroups and the blue dots are heterosexual subgroups. And what you can see from this first graph, this is showing you the average age of the samples, spanning from about 25 to 55. And there's basically no discernible pattern here. Rates of suicide attempts remain elevated even among those samples that were on average in their 40s and 50s. What happened? Okay, by contrast, there was a trend over time. So here the x-axis is calendar year, going from 1985 to the most recent studies that were completed in 2008. What you can see is that there is a trend over time. So in other words, the prevalence of suicide attempts among sexual minorities in recent years was lower than those studies conducted in the 1980s. This is probably not surprising, but there's still a lot of heterogeneity. Why are there still some samples that are reporting upwards of 30% suicide attempts? So the next 2 graphs are just restricted to sexual minority subgroups. These are box plots, so they give you an idea of the distribution of the prevalence, the outcome. With this solid band band in the middle representing the median value. So this first graph, this is my most important graph, so study it hard. It's basically telling you that the way in which we sample people matters. This is probably not a surprise to many of you, but it has really major implications for how we synthesize data on sexual minority health. You can see on the left in community-based samples, so like Sex Now, like the Pride recruited or BAR recruited studies, 20% of the sexual minority participants had attempted suicide. In the general population surveys, where we're taking a random sample and then asking people to report their sexual orientation, it's 16%. And remember that all of our previous systematic reviews on this topic have only included these studies on the right. And then, not surprisingly, the way in which we ask the questions also matters. So if it was self-administered, you're getting people reporting about 20% suicide attempts. If you needed an interviewer to actually ask the question and collect the data, it came out to be about 16%. So these aspects of methods really matter, and they really change the way we describe and summarize health issues, not just suicide, but I think suicide is a useful example here. So to summarize, I'll go back to each one of my three kind of questions. So how strong is the evidence for elevated suicide among sexual minorities in adulthood? Well, 31 studies consistently demonstrated suicide attempts. These are all samples that include people over 21 years of age. The samples which were on average older show comparably high rates. This is ecologic data. It doesn't mean that there aren't age-related patterns within the studies, but just from this broad kind of overview, there's nothing to suggest that as a community phenomenon, suicide goes away when we get older. And I think we need to acknowledge that this effect has diminished with time. So what aspects of the studies themselves can explain all that variability? And I'm just going to focus on one, which is the question about community-based surveys versus random population surveys. For many years, as I noted earlier, community samples were dismissed as having less validity. And this was generally for one of two reasons. One is either, so the quote that I've highlighted at the top, they weren't representative. Representative of what? I don't know, because sexual minority samples should not be representative of the general population because we're different in meaningful ways. But nonetheless, that was a common critique. A second, even more common critique, which is underneath, is that there's some kind of selection bias that renders the people participating in our community studies as healthier than the average person. Something about the fact that they're going to participate in the study means they're probably doing okay. But at least for the outcome I've presented for suicide, that doesn't seem to be the case. We're actually seeing a higher burden of suicide in the community recruited samples. So what's going on there? So I think obviously we need both types of evidence, and both types of evidence have been really important in understanding health disparities that affect gay and bisexual and other sexual minority populations. But community-based samples have some very distinct advantages, and we need to be really clear about them when we start to synthesize data on these topics. They give us a larger sample size of sexual minorities in general, and right along with that, they give us the ability to look at subgroups. This is something that Olivier is going to be talking about in a few minutes, but this is really important. Gay and bisexual men, as we know, are not one monolithic group. There's actually a lot of different aspects of our identities and our social locations that affect our risk for things like suicide, and that's something that we need to be studying. Importantly, community-based samples are recruiting people where the community actually is. When we have interventions that we're going to use for this, we're not going to go out and randomly select households and find gay people to give the interventions to. We're going to go to the same venues where we're recruiting these surveys. And most importantly for me, there's an issue of underreporting sexual minority status. So in the face of societal stigma related to sexual minority identities, we should expect that gay and lesbian and bisexual people will underreport their identity in population-based surveys. This is nothing new. And indeed, in Sex Now 2011, we asked, if you were asked by StatsCan about your sexuality, would you reveal it? And only 2/3 of people said they would. So we need to think really carefully about what that means, the fact that we're missing 1/3 of sexual minority respondents in these broad population-based surveys where we're asking them to identify. Okay, and then the last question is, where are the gaps? And I'm 22 seconds over here. So I'm just going to say really quickly that we now have ample studies which establish this disparity. I think we need to start to understand what's going on in between. What are the mechanisms? What are the stressors? What are the contextual circumstances? What are the pathways? Where do we intervene? And where this has been done, it's really been done focused on sexual minority youth, which is fantastic. And again, Elizabeth's going to talk later about what kinds of school-based interventions work. But we also need to understand how does the aging process affect this relationship between sexuality and suicide. And I'm happy that the other people on my panel are going to answer some of these questions, so I don't have to. So I just want to thank, in particular, Laura Bogert. She's a student with me at U of T. She's my second reviewer, which means that all of these studies that I find so fascinating and spend so much time reading, she has to read them too to tell me if I'm on the right track. So I really appreciate her help, and thank you for giving me an extra minute.